Me da mucho gusto darle la bienvenida a todos los participantes de América Latina que forman parte hoy en día de la red de salud hospitalaria de Hadassah. Es un gusto poder saludarlos. Tenemos gente aquí, México, Chile, Argentina, Brasil, tenemos de Panamá, gente que está participando en este evento. Es el segundo evento de la red de salud de hospitales. La red de salud de hospitales de Hadassah en Latinoamérica tiene como objetivo poder generar oportunidades de colaboración, de cooperación, de intercambio de conocimiento entre Hadassah y el sistema de salud y los hospitales en todo el continente latinoamericano. Y es para nosotros un gusto y un placer poder recibir hoy a los expertos del Hospital Hadassah en Jerusalén en medicina de emergencia. Pienso que qué momento más emergente, más de emergencia, para hablar de la emergencia, que en el medio del tercer invierno, podemos llamarlo, de la era pandémica del coronavirus, en un momento en que la emergencia, si es siempre la puerta de entrada para eventos puntuales, individuales y también para eventos masivos, en este momento se convierte realmente en la puerta de muchos procesos paralelos. Por un lado, lo que sigue siendo una pandemia que sigue teniendo números muy grandes en este momento en Israel, como muchísimos lugares del mundo, prácticamente en todos los lugares del mundo, con una ola de la nueva variante del coronavirus que genera un número muy alto de pacientes positivos, al mismo tiempo con las enfermedades tradicionales del flu, del invierno y por supuesto todo el resto de los casos, más la realidad compleja de la ciudad de Jerusalén, donde está el Hospital Hadassah, que genera toda una complejidad en la administración de la medicina de emergencia, para lo cual tenemos hoy este increíble panel de expertos que va a estar presentando la medicina de emergencia y el modelo de medicina de emergencia del Hospital Hadassah en Jerusalén, el Centro Médico Hadassah, que es líder en innovación y líder en modelos que atienden a la gran masa de la población de Jerusalén y sus alrededores en Israel. Sin más palabras, que podamos encontrar soluciones a la medicina de emergencia y podamos con esta información poder generar más salud y atención correcta a los pacientes que llegan a nuestros hospitales. Y vamos a estar tomando preguntas y al final vamos a poder traer alguna de estas preguntas a nuestros panelistas.
Muchas gracias, Jorge. Voy a hablar en inglés ahora, entonces pueden poner la interpretación desde ahora. I'm going to introduce the two speakers, the panel of speakers that we have tonight. Professor Jacob ASSAF, who's director of the Emergency Medicine Department, Hadassah Hospital and Kerem, and Dr. Ahmed Nava, who's director of the Unit of Emergency Medicine at Hadassah Hospital and Kerem. Dr. NAAMA, thank you for being with us. Professor Jacob ASSAF also, thank you for being with us. I think Dr. NAAMA will start.
Yes, please.
The floor is yours.
Okay, so thank you very much for this introduction, and I would like to welcome everyone for this talk. Actually, I'm pleased now, at least, although we are the COVID timing, but this is the first time we are not going to talk too much or just about COVID. So I'm happy for that. What I'm going to talk is basically just give you a very small head-ups about the structure of our emergency department, emergency medicine department, and what other things that we are doing in academic point of view. How do we basically train our residents and doctors, and how do we try to keep up our highest profile in giving the best care for our patients. So as a hospital point of view, Hadassah Medical Center is just located in Jerusalem. It's a unique hospital from many point of view. It's a community hospital and it's a private hospital. It's belong to the University Hospital, the Hebrew University of Jerusalem. We have a level 1 trauma center, and basically we are a military referral hospital as well. We are a country-wise referral center for many, beside the trauma, for many other diseases, and I will mention that later at this presentation. We have two campuses. We have the Mont Scopus campus and we have the Ein Kerem campus. I will be talking only about our the main campus. It's Ein Kerem, and this is where our department is located. It's basically one of the largest hospitals in Israel. We have about 1,000 beds, about 50 ICU beds, and somewhere between 40 to 50 operating theater. So we have many areas. The structure, it's being like this, where you see the bottom, where you see the fast track. This is basically the main entrance for our department. So we have a fast tracked area together with the reception. Every patient, this is basically the main entrance, and the patients start from there. This is the patient's flow. We have the reception, where every patient have to be registered. Just straightforward, you continue from the entrance. We have the trauma unit together with the main area in the right side, and we have the radiology, which belong to the emergency room. There we have the CT. We have one CT scan just very close to the department, and one room for ultrasound and 2 rooms for Röntgen and X-rays. Beside that, we have our pediatric unit and the observation unit. Currently, we have 12 beds there, but it's currently serves as our biological ED or the COVID area for emergency room. So together, we have 63 rooms. All the rooms, the unique thing about the department now that every single room at the department has a monitor. We can give, we have a designed area for more than 40 beds where we can give care for critically ill patient. So if you want to look a little bit back when we started building the department, basically all the department inside where you see where the highlighted, it's highlighted in black, it's a protected area. It's protected if needed against, given the fact that, you know, we live in a little bit a warmed up area in the Middle East. So this area this emergency room basically can serve as protected area. So in case anything happen, whether it's a war, whether it's some biological gas, chemical hazard, or biohazard, bioterrorism, this area serve as protected, and we can continue working at the same areas. So to build up such a protected area and the building, this thinking have to start, you know, you have to go back and to plan this at the very beginning. So you see that we have inside the room, inside the department, a special doors, which for such protections, special concrete with extra concretes inside, and even you have to think of a ventilation. So as you see from the beginning, it's a ventilation which basically from the very beginning we had the thought that it should, you know, it should give the goal if we have such a big area closed, protected, and a lot of staff is working inside. we have about 95,000 annual visits. So if you want to divide it, it's somewhere between 250 to a busy day, 300 to 30, 350 patients. Sometimes it's basically almost every beginning of a week we have such a big number. Our hospital serves, beside the internal medicine, surgical wards, and the trauma unit, we have a big transplantation center for kidney and liver, a very big oncological center, a referral center. They come from all the state of Israel. They come to get treatment here, and the hemato-oncological unit. Due to the fact that we have such a big hospital, big center located just in the middle of Israel, and this all department reflects the type of patients that we are going to see at the emergency department. So we beside the common presentations of any disease that we might come to any emergency department, we see here a lot of complications, whether complications or any diseases related to all the transplantation, oncology, and the hematological diseases. So the main goal of the emergency department is to treat patients when they come here, but basically from this 250 to 350 patients, when they come in 24 hours, we have to eyeball and to check who are the patients that basically are critically ill, which is roughly somewhere between 10 to 15% of the patients. So with this all big mass or big number, we have to know which patients is basically coming with a cardiac tamponade. These patients, they might come here either walking, or they come here, you know, with the ambulance. So it doesn't really reflect, if not every patient come with the ambulance, they basically are the sickest. And the truth is the opposite. Or such a patient, when they come with a collapsed IVC, these patients in shock, and you know, you have to eyeball them, you have to know that they are there, and you have to treat them properly as fast as possible. Or patients, they come here, you know, after major or minor traumas with a positive fast scan, hemothorax, or as you see in the right in the screen, they might come with just, you know, some vague complaints, abdominal pain, flank pain, and what they basically have a very urgent abdominal aortic aneurysm or ruptured aortic aneurysm. In order to in this big numbers, in order to see and to collect and to eyeball these emergency situations, we have to have a proper emergency medicine staff. So our department is somewhere between 17 to 20 doctors. We have about 70 nurses. We have consultants and residents. Our main goal is basically to train a very good residents and to make a very good residency. Of course, beside our nurses, they do also very good qualifications in emergency medicine and triage and etc. But if we want to talk especially about our residents in their training, so we have 7 residents. We usually try to orient them to be specialists on something. So they are emergency medicine specialists, but they are oriented, they have with a goal to do something specific. So one of our resident is already a surgeon. He's a specialist and he's doing a subspecialty, and the goal is to keep him oriented for trauma, others for toxicology and research, medical education, radiology. So this is very important to keep up a high profile residence. The residency program is basically 4.5 years. We have the main residency, it occurs here at the department, so you have to work most of the time at the emergency department, but you have rotations in internal medicine, intensive care, trauma, pediatrics, and every resident have to be involved in a 6-month research. On top of the education residency that we give for our residents, there is a national course of emergency medicine. It's basically a 1-year course which involves residents from all the states. Israel, it's somehow you can bring together from north to south from different hospitals residents at one spot. So we have a program of 20 meetings where it runs twice a month. Every time it's somewhere, it's just in the middle next to Tel Aviv, where we have our course running, different topics in emergency medicine. I remember about probably 10 years ago when this all started, there were somewhere 15 to 20 residents. Today, we doubled the number. So the current course that is running, we have 45 to 46 residents. We run every week in a weekly base medical simulation at the department. It's, of course, it has a different for a different goal. It could be a communication, medical cases, and it's basically the main goal is, again, train our both doctors, nurses, and our staff how to diagnose and to quickly diagnose patients who need the care and make a better communication. This together will bring better patients care. We run every few months an ultrasound workshop. It could be involved in a point of care ultrasound. Recently, together with our pediatric physician collaboration, we did our first ultrasound course in IV access. On top of that, our doctors need to be one of the best doctors in owning the airway. So we can't have a patient that need urgent intubation or urgent airway management and not to be able to do the best care at this department. So we run every few months airway workshops together with the intensive care anesthetist. It's a teamwork, it's together, it's a collaboration from different departments to, again, for best of the patient care. We are highly active at the academy with the university, with the Hebrew University. So we have rotations at our department from the obligatory from 5th year medical students, and we have elective students coming for 6th year medical students for the whole year. We are actually together with Professor ASSAF and few of our doctors at the department. We do mentor a basic life support course for the university for the last 3 years. And we are starting to give the same principle for the course for the military in next May. We are highly involved with the Israel Association of Emergency Medicine as consultant doctors, as lecturers, mentors, and we at the examination for the Israel Association for the emergency, for the board of the medical board of emergency medicine, actually. Of course, one of the important things beside patient care is to be involved in research. These have been recent 6 to 7 publications in the last year, together with the pediatric department, pediatric emergency medicine department here, and we are actively publish, and we do a clinical and laboratory research at this department. If I want to point probably a few things that have been doing some evolution or a medical evolution beside the things that quickly I mentioned is the ultrasound. Most of our doctors today, they are highly trained in doing point of care ultrasound and critical care ultrasound at the emergency department. We have also been involved in a lot of procedure sedation. And one of the main things that we also introduced to this department is peripheral nerve blocks, patients mainly with the hip fractures. And on top of recently we have started, what we do for them is nerve blocks for the femoral nerve, but also we are expanding our knowledge, and we started doing some nerve block for rib fractures as well, mainly for patients who presented after trauma. This together, it's a quick overview about the structure of our department, the staff of our department, and how do we basically train to do our the best first for our team as teamwork, bringing the team together, and of course always to look forward and to see what are the things that could be new and to bring them bedside to the patient. Thank you.
Thank you. Thank you, Dr. NAAMA.
Thank you so much. Now we're gonna, before we go into questions, I think we're gonna have Professor ASSAF do his presentation. You can share your screen now and the floor is yours. And everyone, a reminder that you can put all your questions in the chat.
Do you hear me?
Yes.
Yes, we hear you.
Good evening, and thank you for the opportunity to talk to you and to bring some taste of Israel, for Israel medicine to South America. Dr. NAAMA described the Department of Emergency Medicine. I want to focus on some extreme situations in which we have to cope from time to time. The main one is mass casualty. Unfortunately, we have a lot of experience in this issue. The others, fortunately, so far, are only theoretical, but still we have, of course, to be prepared for it. As Dr. NAAMA pointed out, Hadassah is a level 1 trauma center, and we see about 1,500 casualties per year. About a little more than half of them are admitted to the hospital. There are many definitions to mass casualties, but generally the idea is a situation in which there is significant disproportion between the number of casualties and the immediate medical resources to treat them. And the significance of it, of course, is a shortage of personnel, shortage of equipment, and of evacuation measures. And we, unfortunately, as I said, experience many kinds of such mass casualty events. Most of them were a result of either terrorism or wars, but some of them also civilian events like this that you can see here, the collapse of the third floor of a wedding room, of a wedding hall, which resulted in more than 300 casualties, and 23 of them were killed. In cases of mass casualties, we say that we have the main 3 T's. I mean, first of all, the triage, and the triage we have to do in the trauma scene, and again at the entrance of the hospital, and again inside the emergency department, and it is to set priorities of the casualties. And then, of course, the treatment from time to time starts at the trauma scene, and many times it is done by laymen, I mean non-professional, and sometimes they cause more damage than help to the patients, to the casualties. And then the transportation, either by ambulances or choppers, depends where the casualties are brought from. Here we see what happens in one of the cases in Jerusalem, and you see there are many bystanders that do not help, but sometimes even interrupt. At the trauma scene, and I'm not going to talk long about the trauma scene, but first of all, you have to set a commanding officer. Someone has to start running the business there. And the guidelines are that the first paramedic who arrives to the area, to the trauma scene, even though instinctively he wants to run and take care of the casualties, he should not do it. He has to stand to take an overview and to report to the back office or to the back center what happens, how many ambulances they have to send, and so on. And then he has to run the triage and the evacuation priorities, and most of all, the evacuation destination, because there's a difference between the capabilities of different hospitals. And you have, if somebody is has mainly head injury, of course, you have to be sure and to make sure that he will be sent to a trauma center where there is neurosurgery. When you come into the emergency department, you have the announcement, and the first thing that you have to do, and this is from our experience, since during the read there are many false alarms, you have to verify that really there is some mass casualty in the town or wherever it is. Then, if you are sure that this is what is happening, you first of all inform the hospital administration, because they have to arrange the hospital. You have to take care, I mean, me as the head of the department, or Dr. NAAMA as the head of the emergency medicine unit, we have to take of our department, but someone have to arrange the whole hospital. You have to arrange operating theaters and so on. So first of all, you have to announce the hospital administration. You must evacuate the ED, which in our department, it's 90% of the time is full of patients. So you have to send them as quick as possible to the department. And then you have to inform senior personnel to bring them. If it's during the day, it's not a problem. If it's during the night or the weekend, you have to bring them from home. You have to reinforce the medical staff to inform other units that are connected to us, the operating theater, the recovery room, blood bank, X-ray, and so on. And then you have to assign a chief physician, usually a chief surgeon, who will be out of the emergency department on the entrance, see the patients as they are coming, in order to decide where to send them, either to the trauma unit or the other parts of the department. And but this is when you start, before the patients are coming, and then you have to prepare the department. You have to, after you evacuated the department, then you prepare the beds, you arrange IV fluid sets and so on. And but after you arrange everything, there are still many, many bottlenecks that you meet in cases of mass casualties. For example, when you evacuate the emergency department, as Ahmed said, there are about 10 to 15 patients that are critically ill. So it's a problem to send them. You have to be assured that while sending them to the department, you don't kill them. And you have to decide whom you send, where you send, to do a good and safe escort by physician or by paramedic, nurses, and so on. Usually, in such cases, since the whole city is aware that sometimes someone happens, everyone calls everyone. Usually there's a collapse of the cellular network, and it's a problem when you try to call physicians and nurses on duty. Another problem is the rate of admission, and it depends on the distance from the trauma scene. If the trauma scene is far from Hadassah, it means that we have enough time from the alarm, from the announcement, until the first casualties appear, so we have enough time in order to prepare everything. But it happened, for example, in one of the cases that the terrorism attack was in a neighborhood about 3 kilometers from Hadassah. Before we heard in the press, in the media, that something happened, casualties started appearing at the emergency department. I said a few words about the triage, I won't repeat it. There is another problem. If you have many casualties, then you do not have the time to do a good, thorough physical examination. So in order not to miss injuries, what we do, we lower the threshold and we send almost everyone to either CT or X-rays. And I will give 2 examples. One was someone who was brought from a neighborhood when there was shooting at the neighborhood from a village in the West Bank, and he had a very small wound in his neck, which was really very small. We did an X-ray just because of the routine, because it was part of a mass casualty. The other example that I will show you was a soldier who was injured in another terrorism attack, a bomb that was exploded on the way to the Jordan Valley. And again, he had a very small wound in his neck, and we did the X-ray just because it was part of mass casualty. And look what we found. In one patient, we found a bullet in his chest, and we cannot think about it just from the small wound he had. And the other one had a huge nail about a few millimeters from his carotid artery. So this is what we do. We lower the threshold for imaging in cases of mass casualty, because this is one of our bottlenecks. The ER is very overcrowded, as you can see. And so there's a lot of interruption in this because there are many bystanders curious, want to see what happens. And you can imagine that not all people here that are standing are really involved in the treatment of the patients. One of the problems, and it's practically, it's very, I couldn't handle it till now. To get rid of some people. And another bottlenecks are, of course, arranging the OR. Sometimes it's overcrowded. Sometimes there are patients that are being operated when something happened, and you have you cannot stop the operation in the middle. So it's another bottleneck, very important. The last bottleneck that I want to show here is the discharge, because there are many. Usually in a mass casualty, about 50, I would say 30 to 50% are lightly injured. So after 2-3 hours, you find the next bottleneck at the area of discharge, because usually there are not enough physicians for this, because most of them are either involved in taking care of the patients in the ER or already run to the OR in order to take care of the casualties. One of the problems is hospital categorization, as I said, and from time to time, since we are trauma level 1, we don't see the problem usually. We don't send casualties from our hospital to other hospitals, but we do get casualties from other hospitals once they found that there is a head injury or something they cannot handle, and they send these casualties to us. It's very important to get information from the trauma scene, and we have a very tight connection with the EMS. There is usually an EMS representative in our emergency department, and he's talking all the time with the people on the scene in order to know, first of all, what really happened. If it's a burn or something, then we know that we have to call more plastic surgeon. He can tell us when the evacuation is ended, and I know that there will be no more injuries and so on. You always have to think about the morning after, because you cannot use everyone who comes to the hospital, because if everyone will be used in order to take care of this event, in the morning there will be nobody left in order to take care of the ongoing hospital life, including those casualties who came with the mass casualty event. If the ER is overloaded, which happens from time to time, then sometimes you have to set an alternative ER. This is, for example, the corridor, the entrance to our outpatient clinic, and we brought, this was in the case of the collapsing of that wedding hall. We had too many patients in a short time, so we just brought beds, physicians, nurses, and equipment, and at the corridor we set another alternative ER. There are many more problems. I won't get into details of all of them because I want to go to the other subjects. But as you can see, first of all, digital photography is very important because, for example, in head injuries, in burns, in a very short time, the head, the face are swollen, and you cannot identify the patient anymore. So it's very important to do digital photography on the entrance to the emergency department, so you can identify him later on when the family arrives. Everyone called the hospital to see if the family, friends, relatives were brought to the hospital. So you have to set an information center, which is usually very, very busy. Of course, the media appear very, very quickly, sometimes before the casualties, and you have to take care of them. It's the interest of the hospital, of course, to be shown in the media on one hand. On the other hand, there is the issue of discrecy, and you have to see that what you don't want that will be published will not be published, and it's another issue to take care of. At the end of every event, you have to do the briefing. We sit in our meeting room in the administration, and you bring everyone who was involved, head of surgery, head of departments, the security people, everyone, the spokesman, and we have to debrief what happened from the moment we got the announcement until the last patient left the emergency department, and we have to see pros and cons, what have to be corrected in the next time, and so on. So this was really in the teaspoon about mass casualty event. In these days, we are all over the world, but also in Israel in the last almost 2 years in the Corona days. Even now, I have a problem here. Speaking with you, we have a Corona emergency department, as Dr. NAAMA said, with 11 beds. And 2 minutes before I started my talk, the chief nurse came and said that now she had 20 patients in this room, and they're all sitting. Just imagine the Corona patients that can be infective. They're sitting in chairs, which. So the problem with this Corona is that this was a new event. There was no one who was experienced in such an event. There's no one from the old school to learn from. We have to learn during we are doing every day or every week. We found or we wrote or we found another article in the literature, and we tried to understand what we are doing. The uniqueness of such an event that this is not as usual problems in medicine in which you have to take care of the patient. You have to be very careful, first of all, about the staff. And so they won't be infected because of two reasons. Of course, first of all, because you take care of your patient, of your staff. And second, if they will be infected, nobody will be left to take care of the patient. At the moment, for example, in Hadassah, we have 300 staff members, of them 40 physicians and more than 100 nurses. They are positive for COVID. So it's a real problem now. Not only the overcrowding department because of the COVID patient, but slowly we have less and less staff to take care of them. We have to construct very quickly a new department, which has to be secured by security people in order not to let others who should not be there enter the department. Of course, as Ahmed already showed, the staff has to be protected with protecting gear. In this period of time between March 2020 and May 2021, we saw more than 7,700 patients suspected. Of them, about 1,500 were positive to corona by CPR. Here you can see the waves between the time of some remission that we have that usually were very short. What we had to do is to set guidelines and checking lists for the physician for intubation and so on, because you have to react differently in such patients, because all these procedures are aerosol spreading and of course are very dangerous to the staff. As usual, in such cases, there are many companies who develop different equipment in order to make short time tests for corona. And we checked one of them. There are many in the market. Unfortunately, we checked it with about more than 700 patients. And unfortunately, this is not a good equipment, so we don't use it. Its sensitivity is about 60%, which means that about 40% people will get the result that they have no corona, but they still have it. So we don't use this equipment. So far as for the corona days, and I will talk about toxicological emergencies. And toxicological emergency is an event in which the hospital has to cope with casualties that were exposed to chemical hazards that dictate a special arrangement of treatment and staff protection. This is a real problem because of the relative easy accessibility to various chemical agents, warfare agents, industrial chemical, and so on. It became a major threat to homeland security here and in other countries in the West world mainly. And we are talking about mass casualty, either toxicological emergency when we have the exposure to these substances, or mass casualty toxicological event when, again, as defined in mass casualty, when the number of casualties are more than the resources that we have to treat. The uniqueness of toxicological and biological and chemical events is in few, I would say, in 4 points. One, that usually you have a very large number of casualties. Second, that it is involved in addition to the mass casualty, which causes a very severe logistic problems, because you have a problem to enter the infected, the contaminated area. You have the problem of evacuating the casualties and so on. But in addition to this, there is a huge psychological impact on the population. And the result of it usually is a huge economical impact on the population. The scenarios that can cause such accident are different: industrial accident, hazard materials, transport accident, and again, terrorism attacks, which we saw unfortunately. So we can see, as I said, road accident, transportation, or industrial, as we had in Israel in 2010, and the terrorism. The terrorism it's an old story. Yes, we see it in the Chinese, and as you can see here, and in Athens, Solon used poisoning stuff in order to, when he had some fight with Kira, and we don't, in Israel, the problem is different, as I said before, different from mass casualties, which we are very experienced. When we are talking about chemical, biological events, we don't have any experience. There's very few events in the whole world. The one that is very famous was in the sarin attack in Tokyo in 1995. And as I said, the characteristic of it is a large number of casualties, usually many of them with similar symptoms, obviously. Some of them, it depends on how the poison was used. If it's in a bomb, for example, then you have many combined casualties, combined injuries of chemical and conventional, of course. And one of the problems that we will have, and this is what happened in Tokyo, by the way, that before someone realized that there is a toxicological issue, people contaminated enter the emergency department. And the diagnosis is made after they have been in the department. And sometimes others were contaminated by them. So the problem is to identify it as quick as possible in order to protect the staff, of course. And what we do usually, we use what we call toxidromes. We try toxidromes, toxidromes, the meaning of it is that you take syndromes and you try from the combination of symptoms to relate the situation of the patient to some sort of toxin. For example, if we take organophosphate, they block acetylcholinesterase at the synapses, and they cause accumulation of acetylcholine at the synapse. The acetylcholinesterase disintegrate the acetylcholine. And of course, when it is accumulated, then you have a constant stimulation of the postsynaptic membrane. It means a lot of secretions, it means fasciculations of the muscles, and so on. So if you try to identify by toxidrome, then you look at the patient. Then you look at the patient and you see the different sites of influence of this acetylcholine. So you'll have altered mental status, you have bradycardia and wheezing because of bronchospasm, and a lot of secretion from the nose, from the mouth, fasciculations of muscles. And if you see all this, then maybe you'll start thinking about the organophosphate. And the treatment, of course, will be according to this, usually with anticholinergic oximes that stops, that block the action of the toxin, and anticonvulsant, which is a symptomatic treatment of the patient. I won't go into this. This is the mechanism of blocking the receptor to the acetylcholine, blocking the acetylcholinesterase, the enzyme, by the toxin. Another sort of chemical toxicologic stuff is the Asphyxian. The main example, the most important example, is cyanide. The cyanide connect to the cytochrome oxidase, the phosphorylation, oxidative phosphorylation chain, and as a matter of fact, it's like choking. It's like stopping the oxygen to the tissues. And the result will be a toxidrome that reflect the action of the cyanide. So there is, of course, influence on the brain with confusion when it's the beginning, but at the end it's seizures, coma, and death. There is tachypnea, tachycardia, nausea, vomiting. And the treatment will be, of course, first of all, 100% oxygen and hydroxycobalamin that bind to the cyanide, and you get the cyanocobalamin that is tied to the thiosulfate. You get thiocyanate, and it's secreted in the kidneys. The last group that I will talk about is the vesicant. The vesicant are substances that attach to the tissues, the skin from outside and tissues inside when it is inhaled or swallowed. And the most famous example, of course, is the mustard. That was the mustard that was used in Syria in 2015, and it's an alkylating agent that is used also for treatment of cancer, as we know, and its influence is on the eyes, on the skin, on the lungs, and at the end also on the hematologic system with developing of leukopenia and so on. And you can see it on the patient, on the skin of the patient. And you find it also when you do chest X-ray, you listen to the lungs and so on. And the treatment is mainly decontamination and supportive measure. There's no antidote. So as I said, all these substances that are being, as a matter of fact, a threat in our area, we don't have the experience of treating it, but still we have the theoretical knowledge about it, and we have to prepare the hospital. So what we do drills of the hospital in which we take demi casualties and we bring them, and then you see that we prepare out of the hospital net stretchers in order to decontaminate, and then another stretchers for the decontaminated casualties. The main issue in toxicological attack is decontamination. Decontamination, taking off the clothes and decontaminating the casualties takes off about 95% of the stuff, unless, of course, it was inhaled. So here you see the decontamination of the patient, and then once he is decontamination, he enters the department, and now the staff do not have to be protected anymore since he is clean. It is very, very problematic to work outside, mainly in the summer, in this protecting gear, and this is why the staff has to go under this shower every 15 or 20 minutes in order to get cooler. The same drills we do, not exactly the same, but the same idea of drills we have for biological event, and there is another kind of protecting the staff, and there is a special stretcher, as you can see, to transfer the patient without contaminating the surrounding, and the protected staff are waiting outside. You know, those who are not contaminated, I mean, those who are not protected are controllers and are not part of the game. And the last one is a radiological event. And the radiological event is generally the same. First of all, you see here that what they brought is an example of a combined injury, radiological and also conventional injury. And then what they do, they have to do decontamination. And after decontamination, they have to check with the Geiger that he is not contaminated anymore with the radiological stuff. And then he's brought, when he's clean, then he's brought inside the department. Part of the training is even teaching the staff how to protect themselves. So you do it step by step. Usually it's problematic. It's not easy to do the protection, to wear the protection gear. So usually we have a special room in which there's someone to assist the staff in order to get the protection. At the end, this is how, look, a staff member who is ready to take care of casualties in radiological, and he has also a personal Geiger ticket in order to be sure that he didn't get any radiation, at least not in a dangerous amount. So as I said, we have to cope from time to time with mass casualty events. Most of them, the vast majority of them are conventional. I hope that the other events that I described cope with. Thank you very much.
Thank you so much, Professor ASSAF, for this great presentation, very detailed and very technical. I'm sure it answered a lot of questions that the participant had. We do have a few questions. We don't have much time, so I will make sure that all the questions will be answered in writing in the next few days. But I just want to mention one or two questions. You did talk about COVID-19 a lot, and we had two questions about COVID-19 and Omicron and the new variant and how it affects, the emergency medicine at this moment, at this time in Hadassah.
There are a few effects. First of all, it appears now, so we have a new wave. After we went down with the corona, now we have a new wave. The other point is that this Omicron, this variant, is more infective. The result of the infection is more, appears earlier than the Delta. I mean, once you're infected, within 2-3 days, you'll have the symptoms. But the most important, the disease is much, much, much less severe. So we don't see as many severe patients as we saw in the Delta wave. One of our problems is that there are many, well, if I can divide the patients who come to the biological emergency room, there are two kinds of patients. Those patients who come because of the corona, and those patients who come and they have corona. I mean, they come, as usual, since there are many infected people outside there, yes? And if you take 1,000 citizens, just without any relation to the corona, some of them will have chest pain, some of them will have diarrhea, they will have something else, they will have some accident, they will cut their hand while doing a salad. So the same casualties, not casualties, the same cases you have with those who are somehow have corona. Either they have corona and they know that they have corona, or they're asymptomatic. They do not even know that they have corona. So this is why we have these two kinds of patients. Those who come because they're sick because of the corona. This is the very easy. We know what to do with them. The problem is the other people. And what is the problem? The main problem, some of them, for example, someone comes with chest pain. Yes, he comes with chest pain and no other symptoms. So we don't put him in the corona. We put him in the usual ER. And he's walking there and he sees people and he meets the staff. And then we find that he's corona, that he's corona positive. And meanwhile, maybe he already infected the staff. So because of this problem, we gave, Ahmed and me, we gave about a few days ago, we gave a new instruction that the staff has to go protected with mask, with covering the eyes and everything to every patient. Even if, I mean, we do not go in full protection, with protection gear, we not go with the gown and so on, but at least covering the face with the protection of the eyes, and we changed the mask to 95 N95, which is better than the usual surgical. So these are the main issues that are related to the Omicron.
Thank you. So protecting the staff to be able to protect the patients.
Right, right.
All right. Thank you. Thank you so much to both of you. If you have a few closing remarks, maybe a few words for each of you, and then we'll let everyone go because we're over time.
Ahmed.
Well, thank you for this event. Actually, you know, when we prepare for such talks, it's a pleasure because somehow we stop the chaos that we have been living for the last year, and we start you know, bringing numbers and stuff and put them in a PowerPoint presentation. It's a sort of break for us. I really thank you for this opportunity, for you, for Jorge and Hadassah International, and thanks for all the participants that have been here with us. Hopefully, after the COVID area, we will be able to probably do some collaborations face-to-face, and it would be much nicer than all these Zoom meetings.
Thank you. Professor Asssaf, a few words.
First of all, I want to thank you very much. It's a real pleasure, pleasure and a real honor. I want to point out three things. First of all, that as Ahmed said, it was a good escape because it was very good. We have a problem now, as I told you, the COVID area is overloaded. So the head of the hospital called me, so I could tell him, look, in 2 minutes, I'm starting a lecture. Please leave me alone for 1 hour. So 1 hour rest is a long time today. Second, I live in a kibbutz Nativ Alamedei, and there's a large group in my kibbutz that came from Argentina and from Brazil. So for me, it's another pleasure to make a talk to Latin America. And the third one is I'm not as young as Ahmed. And I came to this hospital 50 years ago. And for me, it's amazing. It's amazing, you know, to sit here in my department, in my office, and to make a talk to so many people in South America is a little bit like a miracle, I must say. So again, thank you very much.
Thank you, Professor Asssaf. Jorge would like to say a few words.
Just 2 words, and I say this in English, and I know that our interpreter is translating to Spanish. I want to thank you so much, Dr. NAAMA, Professor Kobi, Asssaf, for taking this time. I'm very happy that this means also some good break for you. We really consider you heroes that are doing, you know, the maximum you can. Have been doing this for the last 2 years for your entire careers, but this is an extraordinary time, and I think that we everybody who participated on this event from South America, from Latin America, is thankful for the time that you have taken from this very busy crisis you are dealing with. You know, the collaboration between Hadassah and Latin America is very strong, and we created this network in order to make that even stronger, so that we can see and exchange experiences. And this is the time that, you know, changing these experiences is more important than ever. And it's one thing that I think I take from this, and I want to take everybody, is I know what you are dealing with, the volume, a massive amount of patients coming through your emergency right now, as you very well expressed. But what I take from you is both of your smiles, that you don't blink, you don't get nervous, that you have the stamina, the blood to deal with whatever it takes and whatever comes. And for that, which represents the work that many other people, probably many of our participants today in South America, those heroes who are at the front line of emergency medicine, dealing today with the probably most unprecedented emergency in the history of humankind. We thank you for the work you do. We appreciate that, and we wish you to grow from success to keep healing the world. Thank you so much.
Thank you very much.
Thank you, everyone. Thank you to the participants and to our beautiful panel. We spoke about collaborations a little bit, and we had a question about collaborations. We do have international collaborations in different formats between Hadassah and other institutions around the world for research, for education, and other things. I will be sending some information to follow up on this to everyone. So thank you so much, and see you at the next event.
Thank you.
Bye-bye.